Welcome, everyone. I'm Jennifer Rolls-Root, the co-director of the California Evidence-Based Clearinghouse for Child Welfare, or CEBC. I'd like to thank you all for joining us and welcome you to the webinar. We've muted your phones due to the high number of participants attending, so if you are experiencing any technical difficulties or have any urgent questions, please use the Q&A pod, which is located at the bottom of the screen, and we'll do our best to assist you. We'll also answer questions after the completion of the webinar. You can find the PDFs of the webinar PowerPoint slides and any other webinar relevant materials in the bottom left corner of the screen in front of you. Lastly, you'll receive an email with a link shortly after the conclusion of this webinar to complete a short and easy survey so we continue to improve our webinars and make them as useful and beneficial as possible in the future. The learning objectives for today's webinar are, 1, to help you understand the benefits of Medicaid reimbursement for child welfare services, 2, to establish familiarity with the process and considerations of collaborating with a state Medicaid agency to implement new services, and 3, to illustrate an example of successfully implemented Medicaid reimbursed evidence-based practices, including the approval process and financing structures. Again, today's webinar is brought to you by the CEBC, and we are pleased to have some wonderful presenters for you today. Brief introductions for them, and then we'll go ahead and get started. Morgan Cole, who will be our first presenter, works with jurisdictions and organizations across the country to provide intensive strategic consulting and technical assistance in the areas of child welfare, Medicaid, and behavioral policy. Ms. Cole holds a BA from Dartmouth College and a Master of Public Policy from Johns Hopkins University, where she also received a certificate in maternal and child health. She has worked internationally and domestically with nonprofit organizations, rural health providers, and state and federal governments to increase access to health and social support services for vulnerable populations. We will also be hearing from Shannon M. Fagan, who is the Director of the Bureau of Children's Behavioral Health Services, Office of Mental Health and Substance Use Services under the Department of Human Services of Pennsylvania. Ms. Fagan is responsible for the policy, program, and operations of the Children's Bureau. Shannon obtained her bachelor's degree at Penn State University in Human Development and Family Studies and her master's degree in Child Development and Child Care from the School of Social Work at the University of Pittsburgh. Last but not least, our final presenter will be Emily L. Simmons Hall, who is the Program Manager for the Pennsylvania Department of Human Services. She is responsible for expanding and overseeing all child-centered, evidence-based mental health programs in the Commonwealth. Ebony received her master's in social work from the University of Pittsburgh and is currently completing her dissertation for a PhD in psychology from Walden University. Ebony is married to Francisco Javier Vasquez and is a proud mother of Essence Hall. And now I will turn it over to our presenters.
Thank you. This is Morgan Cole. I appreciate the introduction and the opportunity to talk with you all today. I work with the Annie E. Casey Foundation's Child Welfare Strategy Group, and we found, particularly in the last couple of years, we're working with a lot of states that are tackling just this topic, how to make their resources go as far as possible and deliver quality services to the child welfare population. And one good approach for that is considering Medicaid-reimbursed EBPs for the child welfare population. So this is a timely opportunity. So I'm going to start by talking a little bit about the value of Medicaid-funded EBPs and why those can be a good match for one another. Then we'll move on to talking a bit about what partnering with Medicaid can look like. Often Medicaid folks and child welfare agencies tend to speak a bit of a different language. So having some understanding of the perspective that Medicaid is coming from and the processes and considerations that they have when developing a new service is helpful in building that partnership. So I'll talk some about that federal approval process, as well as the fiscal considerations that Medicaid agencies are frequently dealing with. Then we'll talk a bit about stakeholder involvement and how to align your systems to ensure that new evidence-based practices that are put in place for the child welfare population and more broadly through Medicaid are set up for success. And then before I turn things over to my co-presenters, I'll just give a few examples of states that have done so successfully in terms of implementing EBPs through Medicaid and have taken different approaches to do so. So a little bit of food for thought of how you might do so or what different approaches are out there. So as everyone on this call is likely very familiar, the child welfare field is often operating with really limited resources, trying to serve an especially vulnerable population. So we need to spend our money wisely, and by definition, in many ways, evidence-based practices are a strong investment. They've been demonstrated to be effective. They have a well-developed model and parameters for them. And increasingly, there's a growing cadre of EBPs to choose from. And you have resources like CEBC that has an easy-to-use resource to identify which services may be the best fit for the particular population that you're attempting to serve. And increasingly, there are EBPs that are targeted, developed, or adapted to serve really niche populations that in the past it may have been more difficult to find well-developed service models to effectively serve. So the nature of Medicaid allows you to stretch your dollars further in this resource-limited setting. Because Medicaid has a federal match to it, meaning the federal government will reimburse at minimum 50 cents on the dollar to every dollar paid out by the state for Medicaid services, that means that at minimum you're doubling your buying power. In some states where the match rate is much higher, it could be even more so. So instead of spending what are often limited for e-funding or state-only dollars on services that may meet the requirements for being Medicaid reimbursable, it's the smart thing to do to look at these services and determine, is this something that could potentially be reimbursable under Medicaid, allowing us to stretch our dollar further and expand services potentially. The Medicaid reimbursement process, though, in terms of getting approval and developing the service and implementing it, can be fairly complex at times, not always, but often, requiring a high level of detailed development on the front end. So EBPs are a good fit for that because a lot of that has already been done to an extent. The services, the models have been built out. Provider qualifications are often very well developed already. There may be even rate-setting methodology that's already developed and in place in other states. So having that knowledge base already developed at the front end can make the process of gaining approval from the federal government and then implementing an EBP for your child welfare population a bit more smooth. So before I move on, I want to take a moment and get a sense of where folks are at in terms of their working relationship between the Child Welfare Agency and your state's Medicaid agency. So we've got a quick poll here to answer just that question. So I know that we have a really good mix of people on the line, so you may not all actually be staff or leadership or managers with your child welfare or Medicaid agencies, but you probably have at least a general understanding, whether you're providers or advocates, et cetera, about what that relationship looks like. So maybe that's very collaborative already. The two agencies meet regularly, work together to identify service gaps, develop new services, oversee them, and ultimately improve services for children and families. Maybe it's somewhat collaborative. You get together occasionally as specific or projects or goals come up. Perhaps it's a little more infrequent. You only communicate when necessary, but generally find yourself working independently in silos. Maybe you don't really have any direct communication or collaboration except at the very top levels once a year around, state budgeting time. Or maybe you would qualify it as actually adversarial, that you really have trouble finding common ground and working together for things. So I'm going to give it just another minute while it looks like more responses are coming through. It looks like we're having a lot already in the infrequent collaboration. And the reason that I ask this is because it's really important to develop that relationship proactively between your Medicaid agency, your child welfare agency, as well as any other agencies that are going to play a role in the development and implementation of new services, whether that's your Department of Human Services, Department of Behavioral Health, those kinds of entities. The more that that relationship can be developed on the front end so that you are not starting from square one when it's time to approach them about developing a new service, it'll make things go much smoother. All right, so it looks like we've got a pretty good mix of responses here. I'm not sure if people can see the results on their screen or not. Yep, there we go. So it looks like, yeah, a lot of people saying that somewhat collaborative or infrequent collaboration. And then we've actually got a couple that have more of an adversarial or non-existent relationship. And we only have 3 folks here who would categorize that as very collaborative. So I think there's definitely, you know, a reason that this can sometimes be a challenge, and we see that here, that that relationship isn't always there. So let's move on to the next slide. All right, so as I said, we all know that relationships are vital in moving anything forward, particularly when you're dealing in, you know, big bureaucracies and complex systems. So developing Medicaid-funded EBPs is no exception to that. We all have the day-to-day demands on our time, the crises that pop up always, and all of the political and fiscal realities that everyone is facing. So the more that you can build that relationship on the front end so that you're not kind of sideswiped by those other realities, the more successful you'll be. And I think a big part of that is just understanding the Medicaid perspective when preparing and kind of making your pitch or just building that relationship with your Medicaid agency and the other agencies or departments that are involved or relevant. And a big piece of that is understanding where they're coming from and some of the key issues that they face in doing their work. One part of that I think is really helpful to understand is what the federal approval process is for developing and rolling out a new Medicaid service. Additionally, fiscal considerations that Medicaid faces are a big part of how they do their work as well. So having an understanding of both of those things, I think, sets people up for, you know, understanding better where they're coming from and being able to work together productively. So starting with the federal approval process. So the Centers for Medicaid and Medicare Services have to approve nearly any new significant Medicaid service that's going to be rolled out in a state. There's a few different ways that states can approach rolling out those new services. One of the most common is a state plan amendment, which has the deceptively relaxing name of a SAW. And that's essentially making an amendment to the state plan, which is the agreement between the state Medicaid agency and the federal government about what your Medicaid system is going to look like, what services are included, all of that. Another option is a waiver. So there's different waiver authorities out there that Medicaid agencies can use. You may have heard of 1115, 1915I, 1915C. These are different options for putting in place new systems or new services that sometimes allow more flexibility than doing a state plan amendment and can also be time limited. Alternatively, some states do decide to rely on using pre-existing reimbursement structures for rolling out new evidence-based practices through Medicaid. So, for example, you may decide as a state that Medicaid is going to begin reimbursing, let's say, assertive community treatment, but they don't want to go through the process of submitting or developing a state plan amendment or doing a full waiver for this. So they may decide to use a pre-existing service code and set of requirements for something like mobile treatment services that is a close fit for it, but already in place, and just begin reimbursing that service using the pre-existing reimbursement structure. While that can be an effective approach, in the long run, it often will result in challenges down the road because you're really trying to fit a square peg into a round hole. So in some cases, it may work, or it may be a good kind of stopgap measure until you have the time to develop more fully another approach to it. But we would caution you against moving forward with that approach too often. So the waiver and state plan approach do require CMS review and approval, and that process, unfortunately, can be fairly lengthy. That might be, if you're really lucky, something like 3 months, more likely around 6 months, 9 months, a year, that sort of thing. And there can be often a lot of back and forth between CMS and Medicaid, and then coming back hopefully to the child welfare folks and the behavioral health folks and making edits as necessary. However, once a state plan, for example, amendment is approved, that's approved retroactive to the date of submission. So let's say you submit June 1st and you immediately start reimbursing providers for services, for evidence-based practices that they're delivering. As long as the changes to that state plan amendment aren't massively significant, if that's approved December 1st, you'll still receive the federal match, those funds, for the services that were delivered starting June 1st. So all of this is just important to keep in mind as you work with your Medicaid agency to develop new services, knowing how long it really is potentially going to take and the level of detail that's going to be needed in order to develop that new service. And then you don't find yourself in a position where you've promised your stakeholder community that, you know, this new system is going to be put in place or this new service is going to be available, and then you end up having to backtrack because it takes a little bit longer than expected. So this is just an example of some of the elements that go into a SPA. So again, state plan amendment isn't the only way of developing new Medicaid services, but it's a commonly used one. And when a state submits a SPA proposal, that has to include everything from who's the target population, really specifically defined, what is the service definition, what are the provider qualifications, the medical necessity criteria that will determine who is eligible for the service, what are some of the limitations on those services, what is the rate setting methodology. All of those pieces have to go into it. So it's helpful to have some consideration of these and piece through them prior to you know, kind of making your pitch to the Medicaid agency or others. As I mentioned before, the helpful thing about evidence-based practices is that a lot of this work has already been done. It's not that you're developing a whole new model or, you know, a homegrown program from scratch. This stuff already exists in many places and in many cases, so you have that to work from. So that leads us to some of the fiscal considerations that I think are really helpful to be aware of when thinking about Medicaid and the perspective that they're coming from. So as an entitlement, Medicaid services have to be made available statewide to any individuals that meet medical necessity criteria. So there are some exceptions to that. For example, some waivers allow you to not have to do a statewide implementation or to narrow the population eligible based on other factors. But generally, that is the case. So that's really important to think about because that means the budgetary implications for Medicaid are not necessarily the same as the budgetary implications that you might have been thinking about. Let's say, for example, you're coming from a county-run child welfare system that is really interested in, let's say, rolling out MST for the child welfare population in your county. While that may be the population you're attempting to serve, once it gets into the Medicaid state plan, that means that any individuals who meet the medical necessity criteria for that service across the entire state need to be able to get that service, and Medicaid will need to reimburse that. So it's helpful to keep that in mind when working with Medicaid, that's the perspective they're coming at. And for many states, Medicaid is one of the top budget line items. So making sure that costs are kept to a feasible and sustainable level is certainly a consideration for them. Additionally, there's a political challenge of pulling back any services, even if they've proven to be not cost effective or not have particularly good outcomes. Once it gets out there, it's really difficult for Medicaid to then get rid of those. So they're keeping all of these things in mind, and as a result, wanting to make sure that any new services are effective, that service access is targeted and limited to those who need it the most, and that there's hopefully going to be good outcomes and high quality. So again, that's one reason why EBPs can be particularly appealing for the Medicaid population, because there already is some evidence base for these factors in place. The other piece around the fiscal considerations is thinking about net state budgeting and possible cost shifting between different parts of the state budget. Granted, this argument is not always as effective directly with the Medicaid agency, but is so when thinking about it more broadly and perhaps talking with your behavioral health agencies or your governor's office, that kind of thing. So while implementing a new service for children and families, early in life may increase costs for Medicaid, certainly, particularly, in that one population, it very well may decrease costs as you use those as preventive measures to keep kids and families from ending up in these deeper end services later on. So it's hopefully going to decrease costs for perhaps adult behavioral health services, criminal justice services, other areas that will see a benefit in their budget from developing these services and paying for those through Medicaid. So these are all just things to think about as you kind of start to approach your Medicaid agency and other departments and to prepare your kind of proposal accordingly, keeping these things in mind. So for example, doing kind of preliminary cost savings estimates, those sort of things, so that you have something to show them around this piece. So that brings us to this issue of stakeholder involvement and broader system alignment issues. So I've talked a lot about working with the Medicaid agency and the child welfare agency, but there's a lot of other players, as you all know, that are involved in this big picture. And that's going to vary depending on where you are, what system you're working in, all of that. So you may be operating in a managed care setting where you have MCOs or administrative services organizations that really need to be involved in this and may be active decision makers in some of it as well. You're certainly going to have providers that need to have an opportunity to have input at the front end as well as ongoing. And advocates as well. There may be other folks too, but making sure that you're collecting initial input from all of these people and involving them in your implementation plan is really vital, more so than just paying lip service to this. Additionally, making sure that all of your systems are aligned as you're putting in place new services. So everything from what is your referral pathway going to look like? What's your utilization management approach? What kind of oversight is there going to be? And who's responsible for each of these pieces? So who licenses new providers? What's the ongoing monitoring look like? Is that Medicaid? Is that child welfare? Is that behavioral health? Who's responsible for this? And making sure all of those pieces are clear. And then lastly, a lot of providers are coming from different places when you're talking about child welfare providers in particular. So you may have some of the smaller grassroots mom and pop shop type providers who deliver great services but may not have the level of sophistication around electronic billing or working with Medicaid, dealing with that bureaucracy, working with evidence-based practices. So getting a sense of what your provider base looks like and where are the areas that they're potentially going to need some technical assistance and support to get up to speed so that they can successfully join this and get on board with delivering evidence-based practices and billing Medicaid to do so. So lastly, I just want to, there's a few examples up here of different states that have successfully developed and implemented evidence-based practices through Medicaid that serve their child welfare population. Those of you on the line from California are probably familiar with a lot of those that you all have. I included a mix here. There's certainly others, but these are some good ones that have done a range of different services and also have taken varying approaches in how they went about the process of pursuing Medicaid reimbursement for these EBPs. So there are a lot of different routes that you can take, and if you are coming from a jurisdiction that's trying to get some more of these off the ground, there's no need to reinvent the wheel. In many cases, there may be a state out there that has already taken on a similar approach and that you may be able to borrow a lot of their methodology and their approach to replicate that in your own state and tweak it as needed. So I encourage you to do that outreach, to look at what other folks have done and borrow from it as much as you can in cases that have proven successful. So at this point, I'm going to turn things over to Shannon and Ebony, who are going to share with us some of their examples of doing just this in Pennsylvania. They're with the Department of Human Services there and are going to share with us their experience of successfully implementing some of these EBPs in their own state.
Thank you, Morgan. We really appreciate that introduction, and you laid out a really good framework for us to be able to explain how we've done things in Pennsylvania. So we're going to get started here. I'm Shannon Fagan. I'm the director of our Children's Bureau here, and as was said earlier, we do a lot of things here within our office, but it is important to remember that Pennsylvania is a Commonwealth. So our office lays out the, I hate to say bare minimum, but we put out the minimum standards that people must adhere to for whatever models it is that we're going to put into place. So we do have a lot of evidence-based programs within Pennsylvania. We've worked over the years with both juvenile justice and child welfare. There are two systems to assure that these models are working for them as well as for us. And how we've adapted to that and been able to sustain programs is a little bit unique as far as shared funding. And I'm going to turn it over to Ebony to talk about that. Ebony is our resident expert in these areas. Ebony has been monitoring these programs for how many years? About 5 years, and she goes out every year to do site visits to each of the programs to make sure that they're functioning as they should and have model adherence. She also has attended various trainings, has worked with all of our partners on these programs, and is very adept as to what is needed in Pennsylvania to make sure that they're happening correctly. So Ebony, take it away.
Thank you, Shannon. Morgan, thank you for that wonderful presentation. It really was a good segue for us to talk about the things that you were referencing in your presentation and how we've actually put those things into practice. So I thought that was really, really great. We have a lot of different evidence-based programs here in Pennsylvania, but for the purposes of this particular presentation, we're going to talk about functional family therapy, multi-systemic therapy, and multidimensional therapeutic foster care as the programs that we've looked at using Medicaid funding to pay for. This is just a brief overview of some of the criteria and the description of functional family therapy. I'll allow you to certainly read that at your leisure. It's a little in-depth in terms of some exclusionary criteria, what the model looks like, what we're looking for in terms of youth who are admitted into the program, and what would be some criteria for exclusion. I also have a hyperlink at the base of this particular PowerPoint slide that you can certainly click on from one of our partners, the Epicenter, which was initially collecting data for us. They no longer do it for the evidence-based programs, but they certainly still are a really good resource around information as it relates to the evidence-based practices. The lay of the land in terms of functional family therapy here in Pennsylvania. 7 of the 8 functional family therapy providers that we have in Pennsylvania are attached to a base mental health license. And what that means is that they are affiliated and linked to a particular service that is licensed on an annual basis. So they would either be attached to a family-based license, an outpatient license, or a residential treatment facility license. And as long as that license is in good standing, that program is in good standing. So those programs that are attached to a base mental health license don't require the Children's Bureau, particularly myself, to go out and review them on an annual basis because they're already being reviewed based on the license they're affiliated with on an annual basis. For programs that are not affiliated with a base mental health license, they're identified as waivered programs. One of our 8 providers here in Pennsylvania is a waivered program. And so a waivered program requires an annual visit to make sure that the program is adhering to the model as well as medical assistance expectations and standards. So we go out every year to review those programs for compliance. And based on the review, we determine whether or not that program is in good standing and subsequently will receive a 12-month renewal of their waiver, or if there are some clinical issues or concerns, we can make adjustments to the waiver, similar to how an individual will make adjustments to a license. The next program we have is multi-systemic therapy. Again, this slide just kind of outlines some of the criteria that youth need to be admitted to the program, also outlining some exclusionary criteria and some more specs of the program. Again, I've added a hyperlink here that you can review and get additional information, and certainly review at your leisure if you want to get more information as it relates to that program.
I just wanted to add, and I forgot to say, this is Shannon again, that prior to these coming into our Medicaid system, they were part of juvenile justice and child welfare way before they were part of us. So it took a little time to negotiate and talk about how this could be brought into Medicaid, and Ebony's going to talk about that a little bit as we go forward.
In Pennsylvania, we currently have 12 multi-systemic programs. 5 of those 12 programs are waiver programs, and so as I mentioned earlier, that means that we have to go out to those programs on an annual basis to review them for not only model adherence, but for MA compliance. 7 of the 12 programs are not connected to a base mental health license, and so as a result, we don't go out annually, but we do go out every other year to, again, just check for model adherence and MA compliance. But the level of urgency isn't there as it is with our waiver programs because they're already having annual reviews based on their base mental health license. Multi-systemic therapy also has has some adaptions to the service, and one of the adaptions that we have here in Pennsylvania is MST-PSB, or problem sexual behavior. So this is a specialization of MST that deals specifically with this targeted population. The 2 MST-PSB programs that we have here, one is a waivered program and one is a non-waivered program, but because they are adaptions, we go out and review those annually. Okay, and so here's a poll question I have for all of you. We're curious to know if any of you have any MST adaptions, particular problem sexual behavior, or child abuse and neglect, or family integrated transition. So we're just curious to know, based on the individuals that are participating in the call, how many of you have adaptations as it relates to MST? Looks like only a few people have replied. Are we still keeping the poll open here for another minute or two? No one. It looks like the bulk of individuals on the call don't have any adaptations to MST. which is interesting. I mean, this is a growing evidence-based practice. They really are starting to look, these adaptations are really geared towards a change in shifting demographic for individuals who are receiving the service. So, yeah, it's interesting to see that of the individuals on the call and that have responded, 62% don't have any adaptations. I see that 25% also have problem sexual behavior adaptation for MST. Okay, well, that was interesting. Moving right along, right? So when we look at how these evidence-based practices are paid for in Pennsylvania, it's a little different, and there's a couple adjustments to it, and so we want to kind of talk a little bit about that here. Initially, MST and FFT programs in Pennsylvania were grant funded with the Pennsylvania Commission on Crime and Delinquency, and so when those programs receive grant funding, they're able to just solely concentrate on model adherence and doing what's required for the model to implement the service, because everything associated with the model and adherence to the model is reimbursed. At the conclusion of that 3-year grant period, as part of the sustainability program, those MST and FFT programs were required to transition over to medical assistance. And that was a challenge for some of the programs, because some of the things that are reimbursable through some of the things that are required, for model adherence aren't necessarily reimbursable through medical assistance. And that's when we had to come up with a kind of blended funding approach, which I'll talk about here in a minute. Medical assistance required evidence-based programs to not only adhere to model standards, but also comply with medical assistance expectations, which include treatment plans, facilitation of interagency team meetings, and understanding permissible billing. So for example, when they were grant funded, a lot of the programs could attend court and support clients in court, but medical assistance won't reimburse for court attendance. So that was some learning that had to happen with some of the providers in terms of what would be reimbursable and what wouldn't be reimbursable through MA dollars. Many functions embodied in FFT and MST model are not MA reimbursable, like I said, court attendance, some of the travel expenses, some of the things that, again, the model reinforces can't necessarily be paid for through MA. And as a result, a blended funding model ensures that providers are reimbursed for all services rendered. So a blended funding model blends medical assistance funds with county dollars. And those county dollars that are offered are more flexible. So if a MST therapist or a functional family therapist is participating in an evaluation that otherwise might not be reimbursed through MA because it could be perceived as double billing, well, they may be able to secure county dollars for that, and they would still be able to get reimbursed, and the program wouldn't be in jeopardy for providing services and not being able to be compensated for them. This funding model ensures that services such as court attendance and startup coverage prior to MA enrollment are reimbursed. A lot of times individuals who are coming in and receiving MST and FFT may not already be enrolled with MA, but the provider may need to start up and seek to get them connected so that they can receive medical assistance. Well, some of that startup cost obviously wouldn't be covered through MA if the child is not already connected. So counties will cover the startup costs until the child successfully transitions over to medical assistance. And then the provider doesn't lose money in providing services while a child is not yet enrolled in medical assistance. Okay, we have another poll question here. Are any other states using a blended funding model to pay for evidence-based practices such as MST and FFT? Okay, so in looking at some of the responses as they're coming in, a large portion of the individuals who have responded are indicating yes, so you have a level of familiarity with the blended funding approach. Okay, so one of the questions we have down here is, does the base mental health license review include review of medical assistance programs and model fidelity requirement? And the answer is yes. We do conduct reviews. Well, for the base mental health license reviews, I don't facilitate those, so I misread your question. Does the base mental health license review include review of medical assistance programs and model fidelity requirements? I don't facilitate the base mental health license reviews, but I would assume that most of those programs would be looking at medical assistance requirements for retaining the license, so I would have to answer yes to that. Yep. I lost my mouse.
Go toward, oh, I see it, okay.
Okay, here we go. To access county dollars, FFT and MST providers typically solicit the county and ask to be included in the county's needs-based budget. And so that's the budget that the county develops annually, and they make an allocation based on the needs of the county and if this program really meets and accommodates a need for a particular population in that county. The county evaluates the request and assesses the needs of the residents and determines if they can accommodate the request. So they'll assess to see if one of these evidence-based programs is necessary to and can meet the needs, again, of individuals and youth that reside in that county. If they identify that to be the case and they have the allocation, they have the funds available, they'll make an allocation for that particular program so that those things that aren't covered through medical assistance would be covered and they could pay for them through that allocation. Given state budgets and county budgets, those allocations can fluctuate yearly, and inclusion in those county needs-based budgets is assessed annually. So because you were included in the needs-based, a county needs-based budget this year doesn't ensure that you will be included in a county needs-based budget the following year. It doesn't ensure that, or it does not exclude that either. Blended funding can be challenging. It can be challenging on a couple different fronts. You know, county allocations can vary. Given the budgetary climate, you could receive a significant allocation one year and a decrease the next year. So there could be challenges with that, particular for agencies that are looking at providing the service and not really knowing if they will be able to get reimbursed or if that money will expire. The state budget challenges can impact counties' ability to expand their budget, and so we've had some state budgetary challenges here in the Commonwealth, and we've seen how some of those challenges can have an impact, a trickle-down impact on counties and subsequently on counties' abilities to fund some of those human services. With some of those challenges, since 2008, we have lost a series of our evidence-based practices here. We've lost 12 of our FFT providers, one of our MST programs, and all of our multi-therapeutic foster care programs. So I didn't really reference them throughout the PowerPoint because we don't currently have offer this service here in Pennsylvania anymore.
And yeah, I think this is Shannon. I just want to clarify, too, that in Pennsylvania, we are a full managed care state, and we have 5 managed care providers that currently work within our counties over several jurisdictions. So some may have 2 or 3 counties, one has 23 counties. You know, it varies. And each of those managed care companies can improve the rate if they see a need and it's within guidelines. So each year there's rates negotiated, and you know, our providers have the ability to check in and try to lobby for a higher rate, and it can be a determinant with the managed care companies. And I think the specialized programs are one that may be able to be reimbursed at a higher rate due to that specialty service. So that comes into play as well. Like I said, we set the base, and then typically it can go above that if everyone's in agreement. So we've lost a lot of our FFT teams, and especially the MTFC team, for several reasons. One, the rates. Training staff for that program can be very, very expensive as well, from my understanding. And I've been at the state for a year and a half, so I'm still catching up on some of this as well. But training and rehiring staff and startup costs can be difficult for some of our counties. So depending on the need at the county level, the ability to maintain that flexible funding, that the blended funding that Ebony talked about, and then just meet the requirements. If you're not true to the model, the managed care company may put you on a plan of correction, and if it's not working, they can decontract with you. They don't have to keep you in the network. So there are pieces like that as well.
And I think, too, with programs that are grant funded, there's no real limitation in terms of what you're able to do. You adhere to the model and you provide the service. You don't have any restrictions on what's reimbursed and what's not reimbursed. But I think the transition for a lot of programs, once that grant period is over, the transition to medical assistance and some of the rigidity with MA reimbursement presented challenges for some of our providers as well. And they were taking a lot of losses, particularly if they're not able to get included in that needs-based budget. So if you're not able to get included in the needs-based budget, you still have to adhere to the model to retain your license status. And some things that you're providing as it relates to model adherence aren't reimbursable through MA. So that presents a challenge for some of the programs, and they were really losing money. And so that was part of the reason, too. It was particularly challenging for the therapeutic foster care teams.
I see another question that recommendations on engaging MCOs to cover our evidence-based practices. And I was working within a county when we went through this years ago. It was probably eight years ago when we brought in MST to our network at the county that I was in. And it was a lot of discussion with the MCO about establishing medical necessity criteria, who would be referred to the program that would meet our recommendation or our need under medical necessity criteria, and how we would be able to split that funding for the pieces that weren't covered with our juvenile probation department or our child welfare agency. So it was definitely worth the conversation to sit down and strategize over how this would work best for us. And I was in one of 5 managed care companies, so I'm not sure how the rest of them did it, but it seems like it's a good time to sit down and look at your need and your network and say, we want this in and this is how we would like to do it. So, yeah. Is it possible to use pre-existing reimbursement structures while also working on waiver changes?
That may be a question for Morgan.
I can tackle that one if you'd like.
Yeah, I was just going to say, Morgan, that's for you.
Yeah, so I think, as I mentioned before, it can sometimes be a good kind of stopgap measure, and it can actually be useful to take that approach in some cases. So, for example, you may start reimbursing for at least elements of an evidence-based practice on a more piecemeal basis. For example, using more traditional codes like psychotherapy or crisis intervention that Medicaid already reimburses for and providers are familiar with, and paying for that using those codes. And a benefit of that is that would allow you to, over time, develop really an actuarial basis for a more comprehensive rate later on, and have some understanding of what the utilization levels are, and build up some of that knowledge base so that you have a sense of, maybe what are the minimum service requirements that are actually appropriate and feasible and effective for this particular evidence-based practice, as you will have been reimbursing those using different, more, pre-existing structures already. And then when it comes time to develop more of a comprehensive rate or develop your waiver proposal or state plan amendment, you'll have some information to go off of that has been built up by reimbursing the service already in a different structure. looking at some other questions here. Someone asked suggestions on how to repair your relationship with your Medicaid agency or build that up if it hasn't really been in place over time. And Shannon and Ebony may have something to add to this as well, but I would say it's very dependent on where you are. Often a leadership change on either side, whether that's with Medicaid or child welfare, is an opportunity to kind of start fresh with a clean slate as much as possible to start to repair that relationship. Also potentially finding an area where you can collaborate initially that's more neutral and not so much of an ask of the Medicaid agency before you move towards developing new services. So whether that's working together on improving your data sharing or your provider monitoring systems, or if you're able to offer some training to your providers in the child welfare field that are also Medicaid providers, something that benefits both agencies. That's a good way, I would say, to get started before moving into more substantive areas that they may be a bit more skittish about if you haven't had a good relationship in the past. Ebony or Shannon, do you have anything to add to that based on your experiences?
No, I thought your response was right on. I thought that was good.
Okay. Let's see, there's some other questions here. Has any state gotten Medicaid to pay for services that prevent child abuse or neglect from happening in the first place? And that, unfortunately, is a really tough area where in nearly all cases it's not something that Medicaid is going to be able to take on. Prevention services can be tough with that, and since it's so heavily based on meeting medical necessity criteria in terms of child abuse and neglect prior to any of it having happened already, can certainly be a challenge. So I can't think of any off the top of my head. I can look into that a bit more if people want to follow up with me. On a similar note, are there Medicaid-based resources for what is reimbursed where? It would also be helpful for networking and not reinventing the wheel, as you so helpfully pointed out. So there's a lot of different folks that have put together some helpful guides on this sort of thing that give really good examples of what has been done where. For example, the Casey Foundation put one out last year called Partnering with Medicaid, I believe. And there are resources out there, but there's not, to my knowledge, I would love this, a comprehensive kind of database or website that has all of that information there readily accessible. I think that's something I agree would be incredibly useful, particularly because as this question and comment pointed out, there is so much variation between different states with the Medicaid system, so it's hard sometimes to navigate that and determine what the options are that are out there and what's the best fit potentially to try and replicate in your system.
I think we answered the question about why we've lost so many FFT teams and other MTFC teams here in Pennsylvania. And like I said, that's due in part to some of the challenges with securing funding, some of the issues with the rate. So I think we talked about that a little bit already. Any recommendations on engaging MTFs to cover EBPs? I think we did that one too.
I think we've touched on all the questions that have come in so far, and we've got just a couple minutes left. And I will say I'm happy to answer any questions individually if after sitting with this a little while folks have questions and want to reach out. I'm sure Shannon and Ebony would be willing to do that as well. So I can share my email information and a couple resources that I've come across around kind of guides to child welfare, Medicaid, that may be helpful. So I'm happy to share those with folks.
Yeah, I think that will be fine. We'll do the same.
Yeah, if you guys want to send any links out too, CEBC is happy to send it out to all registrants for this webinar.
Okay. Send our email addresses.
And as you can see, somebody asked if the PowerPoint is available, and that is available on the left-hand side of the screen, and that is a PDF of the PowerPoint slides. And if there are no further questions, we'll go ahead and wrap up. And we want to go ahead and thank Morgan, Shannon, and Ebony for a wonderful presentation today. And you'll be receiving an email with a short survey to give us some feedback on today's webinar. And we want to thank you for joining us and hope you all have a great day.
Thank you. You too.
Thank you.
Thank you.
Thank you.